Welcome, everyone, to our discussion on coronary artery disease, a multifaceted condition that profoundly impacts the cardiovascular system. Coronary artery disease, also known as ischemic heart disease, is prevalent and intricate. At its core, it involves the deposition of fibro-fatty plaques within arterial walls, a process termed atherosclerosis. This buildup gradually narrows the arteries, impeding blood flow to the heart, and predisposing individuals to various symptoms and complications. Clinically, patients with coronary artery disease may present with a spectrum of symptoms, including the classic chest pain or discomfort, along with shortness of breath. However, it's crucial to note that coronary artery disease can also manifest with atypical symptoms such as flushing, diaphoresis, and fatigue. This diversity underscores the importance of healthcare providers meticulously differentiating coronary artery disease symptoms from other conditions like gastroesophageal reflux disease to ensure prompt and appropriate management. Understanding the complexities of coronary artery disease is critical for effective diagnosis and management, ultimately improving patient outcomes and quality of life. Let's delve into the intricate interplay of risk factors and pathophysiology underlying coronary artery disease. First and foremost, smoking stands out as a major risk factor for coronary artery disease. Smoking not only impairs the integrity of blood vessels, but also exacerbates vessel damage, especially in individuals with diabetes, further escalating the risk of coronary artery disease. A strong family history of coronary artery disease is another significant contributor to an individual risk profile. This underscores the crucial role of genetic and hereditary factors in disease development. Furthermore, uncontrolled hypertension poses a substantial risk for coronary artery disease. Hypertension compromises the structural integrity of blood vessels, fostering the progression of atherosclerosis and increasing susceptibility to coronary artery disease. Moreover, the cumulative impact of multiple risk factors, including smoking, hypertension, diabetes, obesity, and a family history of coronary artery disease, can potentiate the severity and progression of the disease. Recognizing and understanding these risk factors is pivotal for healthcare providers to implement effective preventive measures and tailor treatment strategies to meet the unique needs of each patient. In summary, comprehending the complex interplay between risk factors and pathophysiology is essential for effectively managing coronary artery disease and mitigating its adverse consequences on cardiovascular health. Let's delve into the distinct characteristics of two forms of angina, stable and unstable. Stable angina is characterized by chest pain or discomfort typically triggered by physical activity or emotional stress. The pain subsides with rest and can be relieved by sublingual nitroglycerin administration. Electrocardiogram ECG findings may appear normal or minimally abnormal. Management of stable angina often entails lifestyle modifications, medications, and occasionally revascularization procedures. On the other hand, unstable angina represents a more severe and evolving manifestation. It may present as new-onset angina, angina at rest, or a worsening of previously stable angina. Patients with unstable angina may exhibit ECG changes, such as ST segment depression, indicating myocardial ischemia. They are at heightened risk of progressing to a myocardial infarction, MI. Management of unstable angina typically involves a combination of medications, including antiplatelet agents, anticoagulants, and in some cases, revascularization procedures. Understanding the differences between stable and unstable angina is crucial for appropriate diagnosis and management, ensuring optimal outcomes for patients. Let's explore the distinct characteristics of two types of myocardial infarction, STEMI and NSTEMI. ST segment elevation myocardial infarction, STEMI, is distinguished by the presence of ST segment elevation on the ECG, indicating a complete blockage of a coronary artery. This constitutes a medical emergency necessitating immediate intervention to restore blood flow and minimize damage to the heart muscle. Treatment options for STEMI include thrombolytic therapy or percutaneous coronary intervention (PCI). In contrast, non-ST segment elevation myocardial infarction (NSTEMI) is characterized by the absence of ST segment elevation on the ECG, signaling a partial blockage of a coronary artery. While still a serious condition, the management approach for NSTEMI may differ from that of STEMI. It typically involves a combination of medications, antiplatelet agents, and potentially revascularization procedures tailored to the individual patient's needs. Understanding the distinctions between STEMI and NSTEMI is crucial for timely diagnosis and appropriate management, ultimately improving outcomes for patients experiencing myocardial infarction. Now, let's delve into the diagnostic approaches employed in evaluating patients with suspected coronary artery disease. The ECG stands as a cornerstone in the diagnostic process. It aids in distinguishing between STEMI and NSTEMI, crucial in determining appropriate management strategies. Additionally, the ECG can uncover other abnormalities indicative of underlying heart disease, offering valuable insights into the patient's cardiac health. Measurement of cardiac enzymes, including troponin and creatine kinase MB, (CKMB), plays a pivotal role in distinguishing between angina and myocardial infarction. Elevated levels of these biomarkers in the setting of myocardial injury aid in confirming the diagnosis of myocardial infarction. Stress testing, conducted via exercise or pharmacological means, provides further diagnostic information regarding the presence and extent of myocardial ischemia. Prognostic indicators such as significant ST segment depression or a drop in blood pressure during stress testing can guide subsequent diagnostic and treatment decisions. By leveraging these diagnostic approaches, healthcare providers can accurately assess and manage patients with suspected coronary artery disease, ensuring timely interventions and optimal outcomes. Let's explore a unique presentation of angina, variant angina, also known as Prince-Metal's angina or vasospastic angina. Variant angina deviates from the typical presentation as it is caused by transient and episodic spasms of the coronary arteries rather than the gradual buildup of atherosclerotic plaque. Patients with variant angina often experience chest pain at rest, with accompanying ST segment elevation on the ECG during acute episodes. Interestingly, this condition is more prevalent in younger individuals, particularly women, and is associated with conditions like Raynaud's phenomenon and migraine headaches. Diagnosis of variant angina typically involves coronary angiography, which can identify the presence of coronary artery spasms. This diagnostic procedure is crucial for confirming the diagnosis and guiding treatment decisions. The treatment approach for acute episodes of variant angina involves the use of sublingual nitroglycerin to alleviate symptoms. For long-term management, calcium channel blockers are often prescribed to prevent vasospasm and reduce the frequency and severity of episodes. Understanding the unique presentation and management of variant angina is essential for healthcare providers to effectively diagnose and treat this condition, ultimately improving outcomes for affected individuals. Let's explore peripheral arterial disease, a condition that runs parallel to coronary artery disease but affects the arteries in the limbs. The ankle brachial index, ABI, serves as a valuable diagnostic tool for peripheral arterial disease evaluation. It's a non-invasive and cost-effective method used to assess blood flow in the lower extremities. An ABI value greater than 1.0 is considered normal, while a value less than 0.9 indicates peripheral arterial disease. Initial medical management of peripheral arterial disease often involves the use of antiplatelet agents such as aspirin or clopidogrel to reduce the risk of cardiovascular events. Additionally, medications like cilostazol or pentoxifylline may be prescribed to improve blood flow and alleviate symptoms. However, when medical management fails to provide adequate relief or in cases of severe or progressive peripheral arterial disease, Surgical interventions may be necessary. Procedures such as angioplasty or bypass surgery are considered to improve blood flow and alleviate symptoms, particularly in cases where limb ischemia is severe. Understanding the diagnosis and management of peripheral arterial disease is crucial for healthcare providers to effectively address this parallel condition, ultimately improving outcomes and quality of life for affected individuals. Let's explore the similarities and differences between unstable angina and non-ST segment elevation myocardial infarction (NSTEMI). Unstable angina is characterized by unpredictable chest pain or discomfort occurring at rest or with minimal exertion. The ECG may display normal or minimally abnormal findings, and cardiac biomarkers are typically not elevated. Management involves a combination of antiplatelet agents, anticoagulants, and potentially revascularization procedures. InSTEMI shares similarities with unstable angina in terms of ECG findings, which may reveal ST segment depression or T-wave inversion. However, InSTEMI is distinguished by the presence of elevated cardiac biomarkers indicating myocardial injury. The treatment approach for NSTEMI is similar to that of unstable angina, encompassing antiplatelet agents, anticoagulants, and potentially revascularization procedures. Additionally, NSTEMI may necessitate thrombolytic therapy or percutaneous coronary intervention to restore blood flow and minimize myocardial damage. Understanding these similarities and differences is essential for accurate diagnosis and appropriate management of patients presenting with acute coronary syndromes. Let's emphasize the importance of rapid intervention in the management of ST segment elevation myocardial infarction, STEMI. Symptom onset. Patients experiencing STEMI typically present with chest pain or discomfort that persists despite rest. Additional symptoms may include shortness of breath, diaphoresis, and nausea, indicating the severity of the condition. ECG diagnosis. The electrocardiogram, ECG, plays a pivotal role in diagnosing STEMI. It reveals characteristic ST segment elevation, a hallmark sign of complete coronary artery blockage. This finding is crucial for prompt identification and initiation of treatment. Rapid intervention. Time is critical in the management of STEMI. Immediate administration of thrombolytics or percutaneous coronary intervention, PCI, is essential to restore blood flow to the affected area and minimize myocardial damage. Delay in intervention can significantly impact patient outcomes, underscoring the urgency of rapid response. In summary, recognizing the symptoms, promptly diagnosing with the ECG, and swiftly initiating treatment through thrombolytics or PCI are paramount in the management of STEMI. Rapid intervention is key to improving patient prognosis and reducing morbidity and mortality associated with this acute cardiac event. Let's discuss important therapeutic considerations in the management of coronary artery disease. Antiplatelet therapy. Aspirin and clopidogrel are cornerstone agents in coronary artery disease management. They inhibit platelet aggregation, thereby preventing the formation of blood clots and reducing the risk of cardiovascular events. Beta blockers and ACE inhibitors, or ARBs. These medications are integral for long-term coronary artery disease management. Beta blockers reduce heart rate and blood pressure, thereby decreasing myocardial oxygen demand and improving cardiac function. ACE inhibitors, or ARBs, help dilate blood vessels, lower blood pressure, and reduce the risk of future cardiovascular events by inhibiting the renin-angiotensin-aldosterone system. Statins. Statins are essential lipid-lowering medications in coronary artery disease management. They lower cholesterol levels, inhibit atherosclerotic plaque progression, and reduce the risk of cardiovascular events. By incorporating these therapeutic considerations into coronary artery disease management, healthcare providers can effectively reduce the burden of the disease, improve patient outcomes, and enhance overall quality of life. Let's visit the revascularization procedures utilized in the management of coronary artery disease, CAD, coronary angiography. This procedure serves as the gold standard for CAD diagnosis. It provides detailed information about the extent and severity of coronary artery disease, guiding subsequent treatment decisions. PCI, percutaneous coronary intervention. Also known as angioplasty, PCI is a minimally invasive procedure aimed at restoring blood flow to the heart. It involves the insertion of a balloon or stent into narrowed or blocked coronary arteries, effectively opening them and improving blood flow. CABG, coronary artery bypass grafting. CABG is a surgical procedure used to treat severe CAD. It involves using a healthy blood vessel, often from the chest or leg, to bypass a blocked or narrowed coronary artery, creating an alternative route for blood flow to the heart. These revascularization procedures are instrumental in relieving symptoms, improving cardiac function, and reducing the risk of adverse cardiovascular events in patients with CAD. The choice of procedure depends on various factors, including the severity and location of coronary artery disease, patients' overall health and preferences, among others. Let's take a look into the prognostic factors and risk stratification in coronary artery disease. Untoward prognostic factors on stress test. During stress testing, significant ST segment depression, a drop in blood pressure, or an inadequate heart rate response can indicate severe coronary artery disease. These findings guide further diagnostic and treatment decisions, helping healthcare providers determine the appropriate management approach for patients. TIMI, thrombolysis and myocardial infarction. Risk score. The TIMI risk score is a valuable tool used to assess the risk of adverse outcomes in patients with unstable angina or STEMI. It considers factors such as age, risk factors, and ECG changes to stratify patients and guide management decisions. Impact of comorbidities. Conditions like diabetes, chronic kidney disease, and heart failure significantly influence the prognosis of patients with coronary artery disease. These comorbidities should be carefully considered when developing a comprehensive treatment plan, as they may affect treatment efficacy and patient outcomes. By understanding and incorporating these prognostic factors and risk stratification tools into clinical practice, healthcare providers can effectively assess patient risk, tailor treatment strategies, and improve outcomes for individuals with coronary artery disease.